First up on the agenda, first of all, welcome back, Senator Talion. First on the agenda is the State Department of Health, Dr. Box.
Good morning, everyone. Chairman Mishler, Representative Cherry, who's not here yet, Senator Talion, and Representative Porter, who's also not here yet. But I thank you for the opportunity to be here today and other members of the committee. I also want to thank Jason and his team at the State Budget Agency for their help in developing this budget with us, and most importantly to thank my team at ISDH who has worked tirelessly to develop our legislative agenda and our budget associated with this and the governor's agenda items. I'm going to speak a little bit about our mission in general, and then I'll turn it over to Aaron to speak a little bit more about our budget requests specifically. Our mission, obviously, is to promote, protect, and improve the health for all of our Hoosiers across the state. And our vision would be that we would actually produce a healthier and a safer Indiana going forward. I am the State Health Commissioner for just over a year now, so this is my first time to present at a budget committee. We have a Deputy Health Commissioner, and we have a Chief of Staff. And for the first time, we actually have a full-time Chief Medical Officer, which is a big advancement for our agency. We have 3 Assistant Commissioners that are over Health and Human Services, Consumer Services and Healthcare Legislation, and Public Health Protection and Laboratory Services. Each commission then oversees different program areas within the agency. And I provided basically this agency structure or org chart so that if you wanted to see the further breakdown of our divisions and programs with the agency, you would have that. As you can see, our agency covers a wide spectrum of issues that impact the health and the safety of Hoosiers across our state. ISDH has 4 key priority areas that represent the major health challenges of our day. They are infant mortality, the opioid epidemic, smoking for both adults and our youth, and obesity and the health-related issues that are associated with obesity in our state. In 2016, Indiana's infant mortality rate of 7.5 deaths per 1,000 live births made us the 7th highest infant mortality rate in the nation. I'm happy to say that actually that rate has gone down with efforts that have been made in the last several years to 7.3 deaths per 1,000 live births, but as opposed to 623 babies that didn't celebrate a first birthday in 2016, we still had 603 babies that didn't celebrate a first birthday. We have lost almost 3,000 babies in the last 5 years with infant mortality. I also want to mention that it's important to note that Indiana has the 3rd highest maternal mortality rate in the nation. As we look at what we are doing to address this, as you probably know, the governor has challenged us to be the best in the Midwest with regards to infant mortality by 2024, and that's going to be quite a challenge because we are the worst in the Midwest at this point. What we have done through the safety pin dollars that you so graciously allotted us in the past is to actually identify several programs that have been successful and to develop programming based on that, which we know will reach these very high risk and disparate populations. Even though our infant mortality rate went down overall, our white infant mortality rate went down from 6.4 to 5.9. Our Hispanic infant mortality rate went down from 9 to 7. But our black infant mortality rate, unfortunately, still went up from 14.4 to 15.3. So as you can see, we have a lot of work to do, and the resources and the programming we deploy need to be dedicated and identified to those high-risk groups. Some of the initiatives that we've set forward as a roadmap to be able to get us there are our perinatal levels of care, which went through as legislation last year. And the purpose behind that is to ensure that moms and babies that have risk factors deliver at a facility with the appropriate level of not only personnel, but technology and also equipment to make sure that we are able to manage those risk factors. We know in states where these perinatal levels of care have been established for both mom and for baby, that not only decreases infant mortality and morbidity, but it decreases maternal morbidity going forward also. We have developed an OB Navigator program. Dr. Waltho and I at FSSA have been working on this, again, based on what we have found from our safety pin programs. And specifically, this is to attach what we call an OB Navigator to our high-risk obstetrical Medicaid populations from our 13, the regions surrounding our 13 highest risk zip codes, to basically walk them through their pregnancy, to address those factors that we know, if left untreated or unaddressed, will actually increase their risk for infant mortality and maternal mortality. Most important of those being getting women into care as early as possible in their first trimester, and then maintaining that care throughout the pregnancy and for at least the first year afterwards. Also addressing those medical factors like having high blood pressure, having diabetes or obesity that places you at risk for those. Also addressing things like substance use disorder and smoking, which can increase the risk for infant mortality and maternal mortality. And making sure that women know the resources that are available to them. As we go forward and address this, we need to also address those socioeconomic factors that become barriers to women in these high-risk populations for getting care and remaining in care, and then getting their children into care and maintaining that care. We also need to address the issues that we have in our rural areas. We have 33 counties now that either have no hospital or their hospital has no obstetrical services. And in those areas, we also do not have any prenatal or obstetrical care or minimal amounts. So being able to work with those counties that do have a large amount of obstetrical services to deploy from those counties and maybe an advanced practice nurse or a nurse midwife that can actually get out into the counties and deliver care closer to home so that we can at least get women into care in a way that is more serviceable for them. We need to decrease maternal smoking, and I'll talk a little bit more about that. And maternal mortality, addressing that with our Maternal Mortality Review Committee, and I'll also address that more. We have had a pilot program based on some money that you were able to provide for us throughout the state, which now includes 29 of our 86 delivering hospitals, where we have actually studied perinatal substance use disorder throughout the pregnancy. It started basically to address neonatal abstinence syndrome, which is when a child goes through withdrawal symptoms based on maternal drug use. What we found is that we really need to wrap these women with care with some type of an OB navigator. We also need to wrap them with mental health services, with medication-provided assistance, and address those socioeconomic factors that help them to get into recovery and stay in recovery. So the governor has taken as part of his agenda a mandatory verbal screen that is basically a validated verbal screen for substance use disorder for all pregnant women. That allows us to identify women at a key time in pregnancy, and if a woman is ever more likely to get care, it's when she's pregnant or has a newborn at home. So our goal, of course, is to get more women in recovery and not only improve the maternal health, but also improve the health of the baby at birth. The opioid epidemic remains a significant issue, and so I've given you our data from 2016 and our data from 2017. As you can see, we've still had a significant increase in overdose deaths in the state of Indiana from 1,518 in 2016 to 1,809 in 2017. You can see that in 16, 52% of those deaths were opioid-related, and in 17, 63%. And we believe that's because of the increased fentanyl that we are seeing mixed with our drugs. We're also seeing still an increase in the number of patients making it to the emergency room and getting care in the emergency room for opioid overdose. And we believe that is partially related to the naloxone that is saving more people in the field and actually allowing them to get to the emergency room. The State Department of Health has been working to distribute naloxone, which is the agent to reverse overdose opioid effects, and have distributed more than 27,000 kits to local health departments across the state and 5,300 kits to first responders throughout the state. We have also conducted naloxone training throughout the state to help communities to know how to administer that, and are working with our faith-based organizations who have had an interest in learning more about substance use disorder and medication-assisted therapy and how to administer naloxone. Our pharmacists still operate under the opt-in.in.gov standing order for naloxone for lay people who desire to be able to administer naloxone. In 2018, you probably know that the legislation required that all coroners submit a standard toxicology report for any individual who died of a suspected overdose death. By January 1st, we will have all 92 coroners actively involved in this and sending their labs to a consistent lab, or one of two labs, which will then come back directly to the State Department of Health and to the coroners themselves. So we will have more real-time data about what our individuals across the state are dying from and also where this is in communities, and allow us to act accordingly. We've also been providing training and education to the coroners because we found that as we looked at death certificates, there was a very broad, kind of unspecified drug substance that they would check on the death certificates. And so we've been trying to get more specific with this. This toxicology report allows them to do that. And we've actually brought the unspecified designation that they've been putting on the death certificates down from 36% to 20% within this past year. Smoking cessation, as you know, Indiana has the 10th highest smoking rate in the nation. A full 21% of our adults smoke on a daily basis. 13.5% of our pregnant women smoke. That's well over 2 times the national average. And when you look at our Medicaid moms, 24% of them smoke. We know also, unfortunately, that our youth tobacco survey, that our 2018 data showed that we'd had a 45% increase in vaping in our high school seniors here in the state. Smoking is the single most preventable cause of death and disease in our state, and we lose over 11,000 Hoosiers per year with this. Actually, every household in the state of Indiana shares in this cost. For every pack of cigarettes that we sell in the state of Indiana, the state spends $15.90 on healthcare costs, on lost productivity, and premature deaths associated with this. At the State Department of Health, we continue to support the Indiana Tobacco Quit line, the 1-800-QUIT-NOW, and we've serviced over 150,000 Hoosiers who have been reached and have a 30% quit rate. I know that probably doesn't sound very good to you, but if you've ever tried to quit smoking, you'll understand that is actually a very good rate, and when you look at that nationally, it is a very good rate. We have been reaching priority populations such as our childbearing age women, and also some of our disparate populations that tend to smoke at a higher rate through multiple pathways through our community-based tobacco cessation programs. We're also helping pregnant women to quit smoking and have Baby and Me Tobacco-Free program, which is for both the pregnant mom and for her partner throughout the entire pregnancy and the first year after pregnancy, and we have that in 60 of our counties. We'd like to expand smoking cessation programs for pregnant moms into every county. We're also working to address our concerns and the state's concerns about increased e-cigarette use amongst our youth across the state. ISDH has used our local control tobacco coalitions to educate communities about the risks associated with this and also offer education in our school systems. We are currently collecting data about all tobacco use, whether that's smokeless tobacco, vaping, or smoking in the schools. And we have seen a decrease in the actual smoking in schools alongside the increased vaping in our schools. October 1st, I sent a letter to the schools alerting them about this risk and offering the help of the Indiana State Department of Health and our free resources for education within the school systems. Indiana is now the 12th most obese state in the nation. That is better than it was 10th. Unfortunately, I'd like to say that's because we've lost weight, but it just is the fact that we didn't gain weight as fast as some of our other states did. A full 2/3 of our adults are either overweight or have obesity, and 1/3 of our children are overweight or have obesity. We know that obesity increases the risk for high blood pressure and diabetes, and these increase the risk for the #1 cause of death in the state of Indiana for both men and women, and that is heart disease. It also increases the risk for stroke, which is the fifth cause of death in the state of Indiana. Obesity costs the state of Indiana about $3.5 billion per year in related health care costs, and about 37% of that is absorbed by Medicare and Medicaid. At ISDH, we've been working to increase individuals' physical activities by increasing bike trails and activity centers, by working with child care programming staff to increase physical activity throughout the day, encouraging schools to increase physical activity throughout the day. And we've been working with our WIC to improve access to healthy foods and physical activity. We know that WIC has helped more farmers markets to take SNAP and WIC benefits throughout the state so that healthier foods are more available. And we are collaborating with hospitals to increase breastfeeding, which not only decreases infant mortality, but decreases childhood obesity. And actually, Indiana's WIC program was recognized as one of 2 states, along with Iowa, that had increased breastfeeding support the most. We're also working with the Diabetes Strategic Plan, and we'll have that available to you by December of 2019, and working with our partners on that. And then working to increase the number of national diabetes prevention programs across the state, because we know that is a true evidence-based CDC program that actually helps individuals to exercise more, eat more healthily, and decreases the risk for type 2 diabetes. Other top priorities at the Indiana State Department of Health is to ensure preparedness across the state. I have been working very closely with my cohort Director Langley at the Department of Homeland Security, and our teams have partnered together to have basically town halls in northern, central, and southern Indiana to improve the preparedness of our healthcare coalitions as they've developed a change in how they need to work together across the state. We know that we can't do this alone, so we have been working to improve our partnerships with our sister agencies at FSSH, at Department of Child Services, as I mentioned, at Department of Homeland Securities, and at IDEM. And we're working with our outside partnerships to increase collaboration across our state. As a part of that, for the past year, I've been visiting all 92 counties and making sure that I visit every single state health department and meet as many as possible of the local health officers in addition to their staff. And I've learned a tremendous amount about how healthcare across our state is deployed and about opportunities that my agency has for improvement and areas that we are actually succeeding and doing well. We are working with quality improvement based a lot on the information that we have received, and are seeking federal accreditation for our state health department, because we truly believe that that will not only show us areas that we do a good job, but also areas of improvement and raise kind of all of our quality improvement across the agency. We also have a strategic health plan which matches our state strategic health plan to what our top priorities are, and have worked on that this past year. And we have a quality improvement plan for across the agency and for workforce development within the agency to maintain our workforce throughout the agency. I wanted to take a minute to just address a few outside agency updates that I think it's important that you may want to know. We have continued to battle a hepatitis A outbreak across our state. Indiana normally would have about 20 cases of hepatitis A in the state. This year, as of last week, we've already had 733 cases with 2 deaths, and 333 of those were hospitalizations. So almost 50% of those individuals have been hospitalized. We have distributed and given more than 97,000 vaccines, and distributed more than 27,000 vaccines for health departments and other services to give these vaccines across the state. Knowing that some of our counties needed help, we actually developed strike teams that can be deployed from the State Department of Health if a county is willing to have us come in and help and immunize those high-risk populations. For instance, in the prisons, for individuals who use drugs, or for our homeless population. We are finally going to have our new vital records system in as of the end of April. Our deaths vital record system should be in, and our birth system to follow within that next next month or two. And we're excited to be able to actually link our birth and death records and have more information about births and deaths in the state of Indiana. Our cervical strategic plan is completed, and we'll be presenting that to you at the end of this month. Also, our maternal mortality review committee had an incredible response from professionals across the state to volunteer for this committee to look into why our mothers die at an increased rate in the state of Indiana. And we actually had training this summer with the CDC to make sure that we got off on the right foot to appropriately investigate these deaths, and have already had our first meeting to start looking at those deaths and investigate them. And now I'd like to turn it over to Aaron Atwell, our CFO, as he goes forward and discuss our budget.
Awesome. Thanks, Dr. Box. So ISTH is here requesting for fiscal year 20 and 21 a budget approximately $367 million. That's up from $343 million in FY18, FY19. ISDH is kind of funded through three different sources, federal funds, general funds, as well as dedicated funding. Our budget consists of about 68% federal funding, 23% dedicated funding, and 9% general funds. A little bit of background, kind of how we're funded in terms of federal funding. So on average, we have about 65 projects going on at any time. Over the last year or so, ISDH has notified 26 new grant opportunities. We proceeded on those 26, 14 were awarded, and we're still waiting pending decisions on 4 of those grant opportunities. So we're consistently going out there trying to find new federal grant opportunities to carry out our program and our vision. So this slide will tell you kind of an overall budget breakdown of our requested budget, how it compares to our state fiscal year 18 and 19 budget for our general as well as our dedicated funding sources. For state fiscal year 20 and 21, we're requesting $117.3 million in our general and dedicated funding. That's up from $111.5 in state fiscal year 18 and 19. Majority of that, as we'll go into a little bit later, is for our OB Navigator program as well as our Youth Risk Behavior Survey. This next slide will kind of give an overall general representation of funding requested out of the general fund. So in state fiscal year 20 and 21, we're requesting $33.9 million. That's up from $31.7 million in state fiscal year 19. As I mentioned a little bit earlier, majority of that funding is for our OB Navigator program and our YRBS, or Youth Risk Behavioral Survey program. Both general fund requested at a total of about $4.4 million a year. You will not see a corresponding increase because there was a corresponding decrease in our overall admin fund as we move forward for 20 and 21. This next slide will kind of give an overall high-level view of our change package requests. As I mentioned a little bit earlier, 2 major initiatives for ISDH as we move forward. Our OB Navigator program funded at $6.6 million over the biennium, at $3.3 million per year, and I think Dr. Boss can talk a little bit more about the vision and the outlay of that OB Navigator program.
So the money for the OB Navigator program in the next 2 years will go toward developing the infrastructure to develop this program so that we can have a nurse and corresponding medical assistants or other professionals that will be able to do a risk assessments and make sure that we assign women basically to not only the hospital system they plan to deliver, but also the level of care that they need with regards to their risk, whether that's nurse-family partnership, whether that's a community health worker, whether that's paramedicine based on where they are in the state, or potentially even healthy families, which is in all 92 of our counties. We also need to develop an infrastructure for getting this data back to us so that we know if we're being successful with the programming that we're developing, and to be able to give that data back to individuals across the state. And this goes hand in hand with our perinatal levels of care to be able to collect and receive and analyze that data. We also would like to have some money to get the APRNs, advanced practice nurses, or nurse midwives that I talked about into these underserved areas to make sure that women are getting into prenatal care in these areas. This would be kind of a seed money to get those programs started. And we'd like to be able to offer some educational grants because we don't at this point have the community health worker workforce across the state that will be able to provide this for all of our high-risk women immediately.
So then the next change package that's requested is $1.1 million a year, $2.2 million over the biennium from the general fund for our Youth Risk Behavior Survey.
And basically, what our goal is here is to try to identify in our high schools across the state the level of risk that is there for those individuals and as a school system to be violent against themselves or violent against their peers. There's a lot of violence that occurs that is not just someone coming in with a gun and shooting individuals. So we want to be able to identify the risk level that's there and then follow going forward any program that might be instituted in connection to mental health support for these school systems and the success that we have with that.
Awesome, thank you. So, and to kind of revert back, so just a little over idea of some of our programs. Out of the $260-some million in federal grants that are requested, about 135 of that, $135 million goes towards our WIC program.
Question?
Yeah, I got a question here. So I'm looking at our infant mortality rate. I know in 2015 we put money into the TIN program, and I know you're requesting some. So I guess what I'm trying to ask is, we keep putting money into these, but are we improving anywhere?
Yes, so when you look at pockets of areas where we have these programs up and running, for instance, we have an OB Navigator program, what they call it, basically a doula program, which is kind of a high-powered labor support coach, where they attach women in early pregnancy and follow them through the pregnancy, labor, and delivery, and then for the first year afterwards. That started in St. Joseph County based on safety pin dollars, and that program has been extremely successful to the point where they have grown into several other counties in northern Indiana, and attaching women to care and then following them through. And those were basically Black doulas initially that started that program within the community. We also have a program in Vanderburgh County that is another option called Pre to 3, which is through the local health department, and they basically have a nurse and community health workers where, again, pregnant women are attached. So the programs that we have developed based on safety pin money is what we're using to go forward to address this as our programming in the future.
Thank you. I don't really have a question, but I do have a comment. Currently, there are a few of us putting together a community paramedicine legislative program. So I would like to talk to you about how that would fit into the OB-GYN part.
Yes.
Thank you.
We have a great program with Crawfordsville in that, and they've actually added the OB program into that.
Expanded for the state, so thank you.
Thank you, Mr. Chairman. Dr. Boxer, you glad to see you here today.
Thank you, sir.
Chairman kind of talked about the safety pin dollars that we've used. What about this mobile app? We put millions of dollars into a mobile app, and I don't know if it's really being utilized. Could you unpack that in regards to the dollars that we expended, our return on investment in regards to the mobile app?
So the mobile app was designed to basically address women in childbearing years who were considering pregnancy, were pregnant, or had delivered a child, to make sure that she was attached to resources and education that could improve the pregnancy outcome in the state of Indiana. Do you have the investment dollars with you on that? I'm really sorry, Representative Taylor, that I don't have those with me, or Porter, I'm sorry. I can get those.
Porter.
I apologize, I'm sorry. But I can certainly get those for you, sir.
Okay.
But I do know that we're expanding that app in the process of making sure that individuals who sign on to that app based on where they are in the community, they will be identified and then be associated with resources right there close to them. So we're going to be able to use...
Yeah, right, and I understand that for like Marion County, where I live, and Lake County, other places, are they really utilizing the mobile app? I mean, how is it being portrayed out in the community? I mean, it's just, how more can we be effective with our return on investment for that mobile app? I'm very concerned about that.
And I would, based on the amount of money that we put into it, have to get back with you with regards to our investment and the current usage for that, sir.
Okay, and I would appreciate, Mr. Chairman, that she would respond to the chairman and then have staff disseminate that information to us. Okay,
Yes, sir.
I want everybody to know I don't want to be in a silo like
Yes, sir.
other things.
Absolutely.
Mr.
Sorry,
Chairman, I have
don't
one
that
more
with me.
question. Yes, thank you. A sickle cell program, I know you had a meeting with Gary Gibson, and we're looking at legislation on beyond those individuals who turn 18 years old, have some more services for them. This is not only in Indiana, but it's also a national trend. Just got back from San Diego's, and the Hispanic Caucus is doing the same thing. So in light of that, where are we doing, are you going to continue to have meetings with Gary Gibson in regards to looking at programs for sickle cell and wraparound services to help coverage those adults who are continue to have crisis, in regards to sickle cell?
Yes, sir. We do have wraparound services, as you know, for ages 0 to 21, but everything kind of falls off at that point. And the discussion that I've had is that when I first started my practice, everyone came in and they knew their sickle cell status. So especially when they were starting to have children, they knew their status, their partner knew their status. But I'm very concerned that these days people don't even know that. So I'm working to try to also get the newborn screen implemented into CHIRP so that individuals will have access to that, not only with their vaccinations, but also with regards to their sickle cell status. But certainly happy to continue to meet. I've met a couple of times with them.
Thank you very much, and I hope we continue to have those real conversations, because that's a community that needs the services. And as a matter of fact, unfortunately, that's a community that is growing in regards to sickle cell and sickle cell trait. Thank you. It is a
Thank you.
health issue.
Thank you, Representative Porter.
Mr. Dudich.
Thank you, Mr. Chairman. Dr. Box, a quick question. On slide 10, you mentioned a 45% increase in high school seniors vaping. You mentioned a letter you sent out to the schools. How is the relationship between the Department of Health, the county departments of health, and the schools going to address it? Obviously, at such a young age, you can have someone for a very long time smoking. So how is that relationship and that communication going to try to curb that increase?
So we have the resources available, and we've offered those resources. Would be happy to help education in any of those schools. Local health departments and schools are under their own home rules, as far as their local county rules. So I can't go in and force that, but certainly have worked to get that message out. And I'm very concerned about the. When we first started questioning individuals, a lot of youth didn't even know there was nicotine in that. They certainly don't know that the Juul has as much nicotine as a whole pack of cigarettes. So getting that education out there, not only to adults, to teachers, administrators, and to youth is so important.
Senator Brown.
Thank you. Thank you, Mr. Chairman. All right, so we spend $7.5 million getting back to the tobacco smoking cessation. Is that correct in that line item I saw? So I assume, and
Yes.
you say the 30% success rate is actually pretty good, which is rather depressing, but do you get a better success rate, for example, among teens or among pregnant women?
Yes, so the community health quit line actually offers more resources for women that are pregnant or for youth. And when we look at the Baby and Me Tobacco Free, that's a one-on-one counseling with a woman and her partner, not only through the entire pregnancy, but for the first year afterwards, and offers incentive programs. We have programs that vary across the state, but we generally see anywhere from a 60 to 75% success rate. So that one-on-one counseling with pregnant women does really make a difference.
60 to 75 success rate with women who are pregnant? Okay.
Stopping.
So if we have a high rate of women smoking who are Medicaid, do they have access to these apps that you have online?
Through their cell phone, yes, for sure.
They have cell phones that are smartphones that they have apps on them.
What we find is that in general, many, many women have cell phones even when they don't have other resources.
On Medicaid, not just women.
On Medicaid, yes, ma'am.
Okay, and so I'm just curious, since we're starting, sort of following with Senator Mishler and Representative Porter, are starting new programs, why we aren't shifting some of those dollars to our youth and/or to the women, instead of, like with the safety pins, starting a new program, the OB Navigator, instead of building those out? Because my understanding too, because they're all at-risk behaviors we're concerned about, right? Smoking, right, getting good prenatal care, for example, specifically with the women who are pregnant. But I guess I'm wondering why we're going to expand this out when we're not sort of shifting resources to where we're getting the best bang for our buck, I guess.
So what I would say to that is that OB Navigation, the beauty of that program is it allows us to address all of those things. If a woman's had a prior preterm birth, we know that that's a #1 risk factor for having another preterm birth. If she's smoking and that OB Navigator, that nurse-family partnership, individual is educated about the consequences of smoking during pregnancy and the opportunities and resources available to quit smoking, that's the best person to be seeing that patient on a regular basis, asking them about the smoking, how much they're doing, and whether they have quit.
Okay, so what has in St. Joe County then, what's their mortality rate? How has that dropped since the safety pin has?
So specifically, that program's only been up and running about 1 year now. So what we see in St. Joe County is that they have had no infant losses during that time. But in all honesty, to actually calculate a single, just based on the communities that they've been working on, infant mortality risk, that's not something that we can really do.
Do you consider St. Joe County an underserved area?
I consider that population underserved in the fact that we have not connected them to care, and that's what our OB Navigator program has done.
Okay, so you're adding, but you're not, this is, the safety pin is separate from the OB Navigator, correct?
The safety pin program is separate from the OB Navigator, correct?
And yet, the OB Navigator is going to reach out to those who are underserved, which most of us would think we're getting back to don't have a hospital with OB delivery.
Actually, I'm sorry, I didn't mean to.
No, go ahead.
So, of our 13 highest risk zip codes, we have 7 of those right here in Marion County, 1 in Lake County and 1 in Allen County. So really there, it's not an issue of not having resources in those areas. It really is an issue of not connecting these at-risk populations to care and then getting them to follow through with care.
Okay, I have to be honest, and I'm a little bit confused, because some of the literature suggests where there isn't that sort of service in terms of a brick-and-mortar structure in the community, that there's no other option for them. You will then deploy, and I'm not really sure how you're going to deploy or how you're going to fund them, but these APNs or midwives, because the presumption is then that they don't have access otherwise, and that's what the OB Navigator. But over here, we have the safety pin, which is up and running, which sounds like it's very successful, which is doing the same thing, and in fact could be in the same community, because now we're suggesting that underserved is not what some of us would think as not having doctors and hospitals in the community, but underserved is the patient doesn't understand how to connect, and so this is going to get in there and connect them. Am I right with that?
Well, I think it's 2 different issues. I think in our rural areas, it's truly not having obstetrical care closer to home, and so the need to get some type of care closer to home and working with, say, for instance, in our central southwestern district, Vigo County, that does have a lot of obstetrical services, to deploy someone to go out to the counties surrounding that. And then in our urban areas, it truly is getting those women connected to care.
Okay, and then just with respect to the survey, I appreciate the suicide prevention and also making sure that our children, trying to catch them before they become violent. And so I'm just wondering, the CDC survey has a lot of questions that relate to risk behavior on sex, alcohol use, seatbelts, what kind of home life you have, et cetera. But the flip side is, has anyone ever done the back end, if you will, of students who have attempted or committed suicide, students who have demonstrated violent behavior, threats, et cetera, and they match this? In other words, there are choices. You can either opt into this survey or not.
Yes, ma'am.
It's going to be, whether or not the parents want their kids to take it, whether or not the school's interested in taking the time out of their day to take this. And then, of course, it's supposed to be anonymous, so you'll have a snapshot of that day of a small subset in a particular school district. So I guess I'm not quite understanding, unless you actually have a name and can say, I'm concerned about Johnny because he's answered these questions.
So I think the idea of this survey is to show school systems where they stand compared to the rest of the state and compared to the rest of the nation, so that school systems can know whether they want to go even deeper and potentially offer the opportunity for every child to have, a screening for adverse childhood experiences, so that you can individualize that. Obviously, we know those individuals that have attempted suicide or have sexually assaulted someone in the school or bullied someone are already at risk for violence and need to be attached to the mental health services that we need to make sure every school has the availability for.
Any other questions? All right, thank you.
Thank you very much.
Next up will be IDEM and Bruno Piggott.
Thank you, Chairman Mishler, members of the committee. It's a pleasure to be able to present the 2021 biennium budget to the committee. My name is Bruno Piggott. I'm the Commissioner of the Department of Environmental Management. What I'd like to talk about is an agency overview first, some of our accomplishments for 2018-19, some of the issues we are facing environmentally, as well as an overview of the budget. And with me is Kim Diller, our Chief Financial Officer. We also have Brian Rockensus, the Chief of Staff of the agency behind me, and Josh Potter, our other budget analyst in the office. With your permission, I'd like to begin with some of our agency overviews. First of all, our agency is tasked with ensuring that regulated entities comply with the Clean Air Act, the Clean Water Act, and the other federal and state environmental laws and rules that are in place. We do that with staff in our offices of air quality, our offices of water quality, Office of Land Quality. We have an Office of Program Support that supports many of the functions in those other offices, including our assistance programs to regulated entities around the state. The Office of the Chief of Staff is in charge of our budget and our IT operations, and our Office of Legal Counsel provides legal counsel to the agency. In terms of our accomplishments for 2018 and 2019, we were determined to continue with our focus on ensuring that the permits we issue are issued on time, in real time, and exceed the required or less than the required statutory time frames. We have 270 days to get a permit out from our NPDES water program, and similar amounts of time for our Clean Air Act permits. Different permits that we issue have different time frames. We issue our permits in about 70% of the time frames that statute requires that we issue them in. So we're determined to continue on that road of ensuring that our permits are done in real time and on time. In addition to that, we've been working to ensure that our inspection reports that we issue to regulated entities are issued in better than the statutory timeframes. State statute allows 45 days after we conduct an inspection to deliver the inspection report to the regulated entity, whether it's a community or an industry. I just don't believe that 45 days is the appropriate time. Our goal to get our inspection reports out is 7 days. We believe in an age where you can order an item from Amazon.com and get it within 2 days. You ought to be able to get an inspection report from our agency within 7 days. And we're employing a variety of different tools to do that. One, we've done process improvement workshops. Two, we're using technology such as SharePoint in the review process. And three, we're working by sending our inspection reports out electronically to facilities around the state. Currently, we're at about 15 days to get our inspection reports done. And ultimately, our goal is 7 days. And our other metrics that the public will be focused on is ensuring that our water is clean and the air is clean. 97.1% of the residents in counties around the state of Indiana have air quality that meets all air quality standards. And 98.24% of Hoosiers have drinking water that meets or exceeds the standards under the Safe Drinking Water Act. In addition to those big picture items, we've been working to distribute funds under a VW settlement. For those who might not be aware, we have been tasked to the state of Indiana received about $41 million from a settlement between the Department of Justice and VW to distribute in grant form for a variety of possible different projects. The governor appointed a committee of people that was charged with determining what projects could be eligible for funding. They've put together a plan to do that, and submitted it to the Department of Justice and the trustee that's running the VW settlement program. Next year, we expect to be able to award grants through this committee to different projects around the state that will help reduce NOx emissions and ensure that we have an impact on reducing pollutants around the state. I'd like to talk about now some of the environmental issues we've been facing in the state of Indiana. As you are probably well aware, the city of East Chicago has a Superfund site, and that Superfund site was a former lead smelter site called USS Lead. And for several years, it's been a Superfund site. And a few years ago, 2 years ago, the mayor in East Chicago expressed concern that residents were living in a public housing project within the borders of the Superfund site, and believed that the cleanup process that was in charge by US EPA wasn't moving quickly enough. The Department of Environmental Management, our colleagues at the State Department of Health, and other agencies, including housing, work together under the leadership of the governor to address lead contamination issues in several ways. The Department of Health got out and tested residents within the Superfund site. The Department of Environmental Management tested water within the Superfund site and throughout the city of East Chicago. The Indiana Finance Authority worked to provide a grant money to ensure that lead service lines in the city of East Chicago were replaced, and that activity's underway. And US EPA accelerated its efforts to remove lead from homes within the Superfund site in East Chicago. That project is still ongoing, and East Chicago is working to replace lead service lines in other parts of the city as well. A second area where we've had environmental issues was in the Riverside neighborhood in the city of Indianapolis. As you're probably well aware, there's a lot of economic development, and there's a robust residential neighborhood in that area, and there were concerns about contamination and groundwater below those areas. And the Department of Environmental Management has been working in that area to identify what possible sources of groundwater there are that exist in those areas, and to direct cleanup of that activities. We've been working in partnership with residents in the community, meeting on a regular basis with the residents to solicit their input and to understand their concerns about that area. And we're moving forward alongside Citizens Energy and others to ensure that both any possible sites are cleaned up and meet all standards. Third activity that we've been working on that has been of concern and has been highlighted in the news recently has been in Franklin, Indiana. As you're probably well aware, residents in Franklin, Indiana, some residents had children that passed away due to cancer. And the Department of Environmental Management has been working in that area, and so has US EPA. The Department of Environmental Management has been working on a site, and US EPA has been working on a different site. Residents, however, were concerned that contamination could be in the water or through soil vapors, and that they were worried that that could cause contamination that could help cause cancer in that area. The Department of Environmental Management worked to sample the surface water in a creek, Hurricane Creek, that runs through the community, test wells in the neighborhood near that community, ensure that we investigated other sites throughout the city of Franklin, Indiana, and test and retest homes where people had concerns that vapors were intruding into the homes. We continue that effort to this day. We're working at a place called Hoagland Tomato, and US EPA is focused on work in an area called, a business called Amphenol that used to be the Bendix Corporation that did have contamination on their property. All of those efforts are designed to ensure that residents have clean and safe drinking water, and that if there are sources of contamination, we identify them and remove them to ensure that the residents of Franklin, Indiana are safe. A fourth area we've been working on is something I'd like to briefly mention, and that's what we call our 404 program. In the state of Indiana, if you're going to impact a wetland, you need to get a permit from IDEM, but you also need to get a permit from the U.S. Army Corps of Engineers, and that permit's called a 404 permit. This system of obtaining permits is bulky. It involves going to one of 3 possible Army Corps locations. It's not straightforward, and it's inefficient. Our desire is to bring all of that permitting process into one place here in Indiana within the Department of Environmental Management. And we believe that that process will ensure the protection of wetlands and ensure that a system of processing permits is most efficiently run. Those are the environmental issues that we've been working on. Let me now talk a little bit about our 2021 budget request. Kim Diller will focus on the details, but I'll give you an overview of the work that we've been doing on our budget. For fiscal year 20, we've got a total budget of $131,203,814. As you can see from the slide, the largest portion of that budget comes from our dedicated funds. And in 2021, the total we'll be requesting is $135,390,223. Again, the largest portion of which comes from our dedicated funds. And we'll show you a graphic here that shows that the largest portion of the money that we use at the Department of Environmental Management comes from the fees that we charge entities for the permits we issue to conduct our permitting, our inspection, and our other work we do at the agency. 19% of our budget consists of federal dollars, and 16% comes from our general funds. Now to give you a more detailed overview of our budget request, Kim Diller.
Before I dive into the change package requests, I do want to give you just an overall view of how we structured our budget for this biennium. We worked with the budget agency to get a more simplified structure compared to the current biennium. And in the past, IDEM has had a lot of transfer funds where the revenue would come into one fund and then be spent out of another, or the appropriations would go into one fund and then be transferred over into another. We really simplified that by doing away with the transfer funds. So when you look at your agency operating account summary, it's going to look a little funky in some places, and funky is a technical term. And so if you have any specific questions, I can cover those here. If you want to dive into more detail, I'm happy to do that offline. So I'm available whenever you need me. So the change package requests that we have in this biennium budget, we have 4. The first is restore the general fund reserve of $1 million. So IDEM gave an extra $1 million in reserves in the current biennium budget to help with the decrease in tax revenues. In order to restore that, because our base budget was built on the fiscal year 18 actuals, to restore that, you have to actually put in a change request package for that. So that's what that $1 million is for. Then we have $2.8 million in general fund for the concentrated animal feeding operation and the confined feeding operation program. The revenue that we receive for this program is not adequate to support the actual cost of the program. So we have, in the current biennium, used dedicated funds to help cover those costs. That can't be sustained in going into the future, so we've put in a request for $2.8 million in general fund dollars to cover that program. The third, as Bruno talked about, the assumption of a 404 program. This $4.1 million is all dedicated funds. It would be from the fees related to that program if the assumption actually came to fruition. And then we have the 3.3% increase in personnel services, which I'm sure you've seen from all other agencies to help with increased costs in health insurance and personnel and those sort of things. So with that, I will take any budget-related questions, and Bruno will cover the program ones.
Thank you, Mr. Chairman. Thank you, first of all, just personally, for addressing the issue in Riverside. I think Representative Porter and I both represent that area. Although that was on track to be designated a Superfund site, we were very happy to see the department work with us to get something done that could get things changed currently. But I want to talk about lead testing because I think it's important to understand where we're at in the state of Indiana. And I'm a little perplexed by this, but you didn't ask for an increase to address the issue in East Chicago. East Chicago has been determined to be a contaminated site. The school had to be closed. The actual housing development had to be closed. You didn't ask for money to clean it up. I'm assuming there's some type of plan to clean that area up?
Yes, sir. The East Chicago is different from the Riverside neighborhood.
Right.
In a couple different ways. Because it's a Superfund site, 90% of the money to clean up that area comes from the Superfund program. So the department only is required to provide 10% to match the expenditures. And so what are we doing? The EPA is focused really, and let me just add to that. The Superfund money comes literally from the responsible parties. And so what EPA has done is called them all to the table and said, look, you are responsible for the lead that has arrived in people's soil, and therefore you should be in charge of paying to clean that up. And therefore, the responsible parties have been the ones that have provided the money under US EPA Superfund to do the cleanup. And we have put together 10% of that to match. And that's well within our budget on a regular basis. In addition to that, we've been working on the lead service line issue. And you mentioned the lead. And so what we've done with the lead service line is our Indiana Finance Authority has been working with East Chicago, and they provided both low interest rate grants to build a new drinking water treatment plant in East Chicago, which has gone online, and then they've got an older plant. And in addition to that, what they did was build into that whole package money to replace all the lead service lines, every single one of them, in the Superfund area for free. So the money isn't coming directly at all, actually, from the IDEM budget, which is why you don't see an increase there. Okay. But the activities on a regular basis are activities that we already have built into our drinking water program and didn't need to increase. We still have people out there, that's part of their job today.
Okay, I just wanted to, I don't want to speak for my colleagues from East Chicago, but I know that something needs to be done. In the past years, one of the constraints for something to be done was that we didn't have budgetary revenue to pay for this. So you're assuring me that the 10% match will not be an issue if we come to some conclusion that there's a cleanup needed in that area?
Yes, sir.
Okay,
I'm sure of it. And we are not only committed in terms of the money, but in terms of the manpower to ensure that those residents have that area cleaned up. And we will push to make sure that EPA does the job to ensure that we're actively accelerating the pace of that cleanup.
Yeah, okay, in the school, that includes the school too, right?
Yes, sir.
Okay, thank you.
Thank you, Mr. Chairman. Thank you very much. So I understand that we are still spending money on an annual basis for the recycling promotion and assistance.
Yes, that's correct.
So, and we also fund e-waste and gives the solid waste districts, I assume, grants, correct, out of that 900,000 per year. But I have two questions or concerns. So we know that now China is not taking most of our, which is a huge source of our recycling. They're not taking any of it. So many haulers are talking about just putting it in a landfill because they have no market for it. And so I'm kind of concerned about that we're promoting something that we don't have a market for unless we're now in the process of creating one and creating industries. But back in the day, I know that a lot of these recyclers locally appreciated the free product. So I'm just wondering where we are with that. My other question is that each county now, this used to be a mandate that each county had to participate in a solid waste district, and that's no longer the case. And so they are the masters of their own destiny. They can put it on their property tax rolls, they can put a permit fee on everyone's household, right? So why are we still so heavily invested in this, I guess?
Well, we have our Recycling Market Development Board and a fund of money that is directly purposed for those grants to different entities. And therefore, it's one of the purpose of the money that is in the Recycle Market Development Board's purview is to hand them out for those recycling activities. But that's mandated activity of ours. And that fund exists, and our job is to ensure that we, with the Recycling Market Development Board, solicit grant proposals and fund them, and we have been doing that.
I didn't understand the mandated activity piece. What did
Well, we have a fund, and the fund calls for grant making through the Recycle Market Development Board. And so those are the activities that we are mandated to conduct, having the board and using those grant dollars through the distribution network, just as we do for a variety of other programs, whether it's our 319 program or other funding programs. Their requirements, and we get money in to distribute for those different purposes. It's certainly a challenge that China is not accepting the same level of recycling that they did in the past, and that's something that each of the entities is struggling with for sure.
Okay, I'm just gonna leave with the comment then. My concern is, like, my county has a very vibrant, rigorous recycling program. They've disbanded their district, and that's at their cost. And they have been unbelievably innovative in taking care of all of these different waste streams and not having them go in landfill. But they're not necessarily being subsidized. So my point is, I think it's almost like the chicken and the egg. If you're gonna subsidize me, then I'm not gonna start my own programs, and you'll fund it for me, and that's my concern. So,
I understand.
thank you.
Thank you, Mr. Chairman. I just have a quick question. During your presentation, your 4 bullet points, the 404 program,
Yes, sir.
is that, are those new dollars, is that fee increase, or in regards to that $4,186,000?
Well, the fees have not been, there's been no fee attached to that. Right now, what we're doing is investigating the idea that if you assumed a program that is currently run out of another agency, the U.S. Army Corps of Engineers conducts the 404 program. They issue permits to Indiana entities, and some are in Louisville, some are in Chicago, some of these U.S. Army Corps offices are in Detroit. And it's terribly inefficient. You come to IDEM, then you go to Louisville, or you go to Chicago, or you go to Detroit to get a permit to do these activities. And what we're saying is that we believe that there's a better way to conduct this business, both for protecting the environment and to ensure that we get 404 permits issued efficiently. And that would be to apply to US EPA and the Corps of Engineers to assume authority over the program. And if we were to assume authority over the program, then we would need to charge fees to issue a permit. And currently,
So it is a fee a fee?
it-
Potentially, if you assume the
If we were
program
granted the
locally?
authority to assume a fee, to assume the program, then that program would be supported through fees. But we have not been granted that authority, and what we're trying to do is investigate what are the options and what's the most efficient way to do business that would both assure environmental protection and efficient service to the residents and businesses in the state of Indiana. And therefore, the way to do that could be through assuming the control over the program here in Indiana. And that is really where we're at with that program.
In that program, if you obtain that program, that would be your scenario at the Amazon. It'd be a lot quicker and to address the issues, right?
It would be a lot quicker for our agency to issue permits than it is to get a permit from our agency, then go to Louisville or Chicago or Detroit if you knew which place
So
to go.
essentially, what our businesses, our residents have a treasure hunt in regards to where they need to go.
Currently, it does seem like a treasure hunt. That's right. Where do I go to get a permit? And it can be confusing, and that's why I think some people just don't know where to go to get what they need to get in order to get their business off the ground.
Thank you, Commissioner. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. Thank you, members of the committee.
Next up, we have the IEDC, Elaine Beadle.
Can you hear me okay? Oh, whoa, yeah, yes we can. Good morning, I'm Elaine Beadle, and I currently have the honor of serving as president of the Indiana Economic Development Corporation. So we're pleased to be in front of you today to share a little bit about what we've done and what we need to be doing to continue to be on a roll, as the governor likes to say, and to continue to be bring the world to Indiana, take the world to Indiana and bring the world back to Indiana. So all kinds of good things are happening, and so we'll jump right into our slides, if that's okay with you. First of all, the whole reason we have an Indiana Economic Development Corporation is to make sure that we have a growing and sustainable economy. And we do that in several different ways. First, we like to create jobs, and we create jobs by looking for opportunities to help businesses expand their footprint in Indiana, looking to attract businesses from outside of Indiana, either nationally or internationally, and by growing our own, by helping our young businesses get started here, grow roots here, and become hopefully large headquarters here. The second way is by increasing wage. We know the importance of helping our Hoosiers to increase their household income by having jobs that have a higher wage than what we average now. And the third way we make sure that we have a growing and sustainable economy is to have a diverse set of businesses within our boundaries, to be able to sustain when any one industry goes through a cycle, because we have a good, again, diverse economy. We need to operate at the speed of business, obviously, so a little bit about us. We have 75 staff members, which is kind of a lean and mean staff. We do with that number business development, which again is attracting and retaining business as well as expanding business. on the domestic side, the international side, as well as innovation and entrepreneurism. So that probably was one tweak we'd do to the slide, is to add that category as well. We have another finance and accounting group, and we have account management and compliance. Obviously, whenever we give an incentive package, one of the things that we want to be sure is that that obligation or that promise that that business made got carried out. And so we make them report to us. Did you create that job, and what was the wage, and was that what we agreed upon? And they don't get the incentive, because all of our incentives are performance-based until they show us that they've either hired or they've spent the dollars, the capital investment, before any kind of incentive, our incentive gets paid to them. We have a budget of about 74 million plus. That's about 0.4% of the general fund budget. That includes not only our incentives that we provide other businesses, but our programmatic and our operation budget as well. So all of those are tied up in that 74 million. We have been on a roll, as the governor would like to say, but we have to maintain a very competitive edge. The IEDC was just started in 2005 by then Governor Mitch Daniels, and it was with the idea that we need to really shine a light on creating jobs and to increasing the economy that we have. And so we've come a long way since 2005. You can see our unemployment rate has gone down significantly since the financial crisis. Our average job postings have gone up. So what we kind of were able to do there, we've had record number of jobs last year. We're on a great track to do something similar this year. We have record low unemployment. Our average wage has gone up. We're well above what the average Hoosier makes with the new jobs that we have committed. There's a lot happening in the tech sector right now with new developments, with automation, et cetera. But thanks really to the great work of the legislature over the last really decade plus, it put Indiana into a position where we are attractive. We're very attractive to businesses, and many businesses that are looking to expand or to move to another location, we get on the short list. And I will tell you that initially, when I first started in this position almost 2 years ago, it seemed like we were pretty reactive because, again, we had all these opportunities coming to us. And one of the things that we want to do, and I'll talk more about that as we go through this presentation, we need to be more proactive. We need to look at what Indiana needs in their businesses to be diverse, and we need to attract them to Indiana through the incentives that we can offer. But when you get third-party accolades, that's when you know that you're doing something right. And we have been ranked #1 in the Midwest, #5 nationally for a great state to do business, and that was by Chief Executive Magazine. We're #2 for infrastructure by CNBC, #2 most affordable state by U.S. News, #2 long-term financial stability, also by U.S. News. So you can see with those out there, again, that's why businesses are looking at us. And again, thanks to the programs and the legislation that you've put in place that has allowed us to do this. But we've had lots of industry growth in advanced manufacturing. You know, 1 out of 5 Hoosiers is involved in the manufacturing sector, so 20% of our working population. Aerospace and defense, huge for us, when we've got great companies here like Rolls-Royce, BAE Systems, Raytheon, GE Aviation, and Arconic. Agribusiness has contributed $31 billion to our economy. We're looking at how we combine science and agriculture and technology, and obviously we've had some success there. Life sciences, we're #2 in the world for exports of life sciences. I often tell people if they know anybody who's had a replacement of a hip or a knee, they probably have something made in Indiana as part of them at that point in time. Logistics, we're #1 in highway accessibility, and so when we come down to say we make things, we grow things, we move things, we're very serious about that. We're better than anyone in the country for doing that. And technology, you know, we are one of the fastest growing tech sectors in the United States. Again, compared to many of the other places, our growth of jobs has been huge in that sector, and we obviously want to continue that. The wages in that sector are high. They're $76,000 on average, so that's what we kind of look for. Cultivating a strong and diverse economy, as I mentioned, that is so important. And as the governor said, to ensure that every Hoosier has the opportunity to live up to their potential right here in Indiana, our challenge is clear. We need to sustain our momentum in economic development and at the same time build on it. This is our task, to take Indiana to the next level. and we couldn't agree with them more. Again, a diverse and a strong economy. So our core strategies in doing this are connectivity, economic diversification, attraction and expansion projects, innovation and entrepreneurship, growing our own, as I mentioned, and the 21st century workforce. You know, we can bring an awful lot of jobs here and introduce Indiana to businesses, but the first thing they ask is, where's the workforce coming from? And so we, even though we wouldn't think about that as being part of our lane, it absolutely is. We have to be able to connect new employers with the workforce and where they might come from at every different level. And so we're working hard to do that as well as attracting and retaining the talent that we already have here. So some of the achievements, as we mentioned, we had a record-breaking year last year in job commitments with an average wage much higher. We had 30,127 job commitments at an average wage for each of those jobs at $27.21 or something close to that. We secured Indiana's first nonstop transatlantic flight, and that was to Paris. And likewise, we were able to support several of our regional airports in what they're doing to get nonstops to, again, help promote business within their communities and bring more businesses into them. Ranked #1 for most active venture capital in the Great Lakes region. And that's the 21 fund through Elevate Ventures. Most people think, oh, what are we doing with that money? What's it mean? It means that we're more active than anyone else in the Great Lakes as far as a venture fund in creating jobs. They helped to fund 292 Indiana startups, and that's significant, and we'll talk a little bit more about that in a second. And we've leveraged private dollars also with those innovation projects that we're doing in a 3P partnership. So our money goes in, but we always get matching dollars from the industry or from others that make these partnerships work. And we've built on our international outreach program hugely, and we'll talk about that as we move through this as well. So building on Indiana's momentum, one of the things that we need to do is to modernize our toolbox, and some of those were announced with the governor's recent announcement of his agenda late last week. And we aren't really changing many, we're really sort of tweaking some of those that we have. In the case of some of them, we're broadening the scope of what projects or what buildings can be included in, like the Dino credit that you may be familiar with, the industrial recovery tax credit. We're expanding that to be other buildings as well as just industrial buildings, still meeting the 100,000 square foot requirement in the 15 years old or older. We want to have our venture tax credit to be transferable because it's a double win for Indiana if we get people outside of Indiana putting money into our businesses that are located here. So it's a double win for us, so we want to move to make that transferable. There are other ways that some of our legislation only applied to the purchase of certain types of equipment for businesses. Well, we want to make it a little bit easier for that credit to apply to refurbished equipment that they may be bringing in. So it's a much better and more friendlier to some of the businesses. And the other thing is headquarters. We really want to encourage headquarters to come here. So we're tweaking the headquarters incentive that we have to allow more small businesses to qualify and to move into Indiana with our help and assistance. So those are just some of the things that we need to modernize as well as to continue to fuel our growth as we indicated there. So what does our budget request look like? First of all, one of the new initiatives by the governor is the innovation grants. And what we see here is something lacking for, again, small businesses. We really are focused on helping to grow our own, but small businesses many times come up with an idea, but they need a little more research or they need a little more assistance, and they can't get it. They don't have the ability to go into Purdue or IU or Notre Dame or Rose-Hulman or some of the others and say, help me with this. So what we want to do is small grants that will allow them to pay for those kinds of services from some of our great research institutions here that can be very helpful in them moving forward their ideas. So those innovation grants are $1.5 million, brand new dollars that we've not had before, but the governor has asked us to administer that. Business and Promotional Fund, no real dollar increase, just the COLA increase, and we'll talk about that in a second. Again, the 21 fund, which is Elevate Ventures, which includes investing in startup companies as well as some of the other entrepreneur and innovation projects that we do come from those funds that help grow our own businesses. And our administrative and Financial Services Fund, that's where you'll see an increase of almost 1.2 million. And that's, again, to help us really focus on international. There's been a lot of expenses there. We've expanded greatly in the international area, and I'll go into that in a second as well. And so we need some funds to support those efforts of what we're doing there, as well as the COLA increase. To talk about international for a second, you know, we have really, I think, upped our game in the international, and it's paid off. It definitely has paid off. If you look at 2017, we made 21 international touches. Either we went to, I think, 11 trips that year, and another 10 came to Indiana. Last year, we made 37 touches. We went on 17 international trips, but we had meetings with another, 16 that came back here. So, I mean, those are the kind of increased volume that we're seeing. And obviously, as we want to expand our reach around the world, we need to have contacts in these other areas, and we do more research. We have done a great deal of research right now on what international countries are actually putting out the most foreign direct investment, FDI, into various states within the United States. Which are those countries, and what sectors are they going into? So we now are armed with that research so that here again we can be proactive and go to those countries that we know are being active in the spaces, and in the spaces that would make sense for Indiana. So those are some of the things that we need to have a little bit of money to help do that as well. So the innovation grants, I've spoken to that probably as much as I need to, but again, it's offering small businesses the opportunity to partner so that they can move their ideas with the help of our universities and a little more quickly. The Business and Promotional and Innovation Fund. Many of you may recall that this was a fund that you all created a couple of years ago that put in a lot of the individual asks that we had into that category. And it included everything from marketing to securing more flights for our regional as well as for all of our airports, and for our public-private partnerships. It was for some of the regional planning collaboration that was going on around the state. It was for quality of place. It was the international operations. So everything kind of got thrown into one fund, which gave us the flexibility, spend it wherever you think you want to. It wasn't quite the total that we needed, but so we've been very judicious. And I was just told this morning that we spent all but 86 cents of that 15 million that was allotted to us this last year. So we're using every dime that we can to promote Indiana in so many different ways. So that's the 15 million and adding, so we're not asking for anything more, just an additional, the COLA that comes with that. But again, we mentioned the international flight to Paris, but we also have, through that fund, did the safety net, as I call it, with airlines move with a non-flight from South Bend to Dallas. And we got the wonderful surprise when we were on the phone with them saying, oh yeah, we're going to do that for you. We're going to go to Dallas, but we're also going to start a nonstop to Charlotte for you as well. So South Bend got kind of a twofer out of that. We've worked with Fort Wayne and some of the things that they're trying to accomplish, as well as Evansville and Gary. So there's various ways that we can help the regional airports from that as well. I mentioned some of the 3P partnerships, public-private partnerships. One of them that got us a great deal of leverage was a public-private partnership that was the Joint University Microelectronics Program, JUMP for short. And this was money that was coming from the Semiconductor Research Corporation. And they were going to fund a 5-year program committing $200 million to 6 different academic research centers. Never in history have 2 of those research centers come from the same state, but they do for us. Both Purdue and Notre Dame will be receiving about $53 million in total out of this $200 million to do research in those areas, along with some of the big names in industry, Intel, Micron, IBM, and Lockheed Martin and Raytheon. So we ended up putting some funds into that, but we got a 17-to-1 leverage. So I think we'd like to do that deal every day that we can to help bring that kind of money to Indiana. Another example is the BIC, the Battery Innovation Center, that was created through IEDC a few years ago to actually explore and to work with businesses on battery innovation and energy storage. And now Cummins has stepped up for a real strong partnership with them. They're using them to prove some of their concepts in the electrification area, as well as they're training a lot of their employees in the area of battery innovation. So they've already trained about 1,000 of the Cummins team. So those are some of the things, again, along with quality of place, the international operations that I already mentioned that will come from the BPI fund. The 21 fund, again, asking for $30 million plus the COLA there. Again, mentioning that the 21 fund had that most active venture capital firm in the Great Lakes, but it was also top 10 most active seed venture capital fund globally. We're in the top 10 globally, and we are getting attention from all around the world as to what we're able to do here and to accomplish here. And we're top 3 most active community impact funds, because 21 Fund also is partnering with different regions around the state where, again, we're matching their dollars into an investment pool to help their local entrepreneurs expand and their local small businesses. So money being put to good use. And I mentioned before, 292 businesses have received startup funds from the 21 Fund. That was a total of $82.4 million, again, from us being invested, but it leveraged even more dollars because we never go into an investment on our own. We leveraged another $554 million in capital to go to those same businesses from other venture capital funds. And right now, the portfolio of companies that we're invested in, their average salary is almost $62,000 a year for their average salary of employment. So I think you can see a lot of good coming out of that. And 84 different counties within Indiana have now been impacted with those 5 regional partnerships that I mentioned earlier. And how some of the companies, one of my favorite is B Corp out of Bloomington. B Corp was started by Ellie Sims and Wyatt Wells. They graduated from IU, and they came up with this great idea on how to monitor beehives. And beehives are very expensive to run, and if you lose it because of disease or other things, you basically have lost a huge investment. So through their technology, they can tell when a beehive is becoming unhealthy, so that something can be done immediately to save that hive and those bees. So she received $750,000 in angel and venture capital funds. She utilized our venture capital investment tax credit to help grow her company. She did a Series A investment round with Elevate Ventures of the 21 Fund, High Alpha, which many of you may recognize here, and several other angel investors. The National Science Foundation has awarded her a 1-year, $225,000 SBIR Phase 1 grant, which is huge. So she's off to a great start, a lot, and thanks to some of the things that we were able to help her with initially. Clear Object is another one in Fishers. Many of you may recognize this. It was Cloud One. John McDonald founded that business. Again, 21 Fund has a $1.2 million investment there, and he also used the VCI tax credits as well. And this is an important company because it's all about Internet of Things. It's about how you monitor what's happening in your advanced manufacturing or your agriculture or your other things, and so it's a great business to be here. The last one being the administration and financial services, again requesting that almost $1.2 million increase to support the operations, as I mentioned before. We haven't had an increase besides COLA in that fund for a while, and it ends up being a 1.6% increase of our total $74 million budget. So with that said, if you have any questions, I'm happy to take them and answer them for you now.
Senator Talley.
Thank you. Yeah, I have a few questions trying to follow this.
Good luck trying to follow that piece of paper.
Exactly. Yeah, that's why I have a few questions.
Difficulty.
So on the first page on the 21st century, you show some changes in the what's dedicated and what's coming out of general fund. What is that about?
Yes, you can answer that.
Thanks, Senator Italian. So back in the previous budget, the 21 Fund received a reappropriation of $10 million from the existing balance within the 21 Fund. a $10 million appropriation from the Department of Insurance Fund and a $10 million appropriation from the general fund. We no longer have that significant outstanding balance within the 21 fund, so that's where the
You no
change-
longer have what?
an outstanding balance to which we could reappropriate that balance. I think there's about $4 million remaining in the fund, or excuse me, $2 million that will be reappropriated in the next.
Okay, so we're adding an extra, basically 8 or so from the general fund.
Correct.
So in a way, that's kind of new money, right?
Yes.
Well, it's coming from a different source, because the
Well,
source that
but
it
the
was
other
coming
source
from-
had money that was already there, and now this one doesn't. Okay. The Orange County, on the next page, is that all gaming money? And is that just an anticipated increase?
That's purely a pass-through. So it's an anticipated increase, I would assume, for that, but we don't touch that money. It just comes for us to pass through to its ongoing purpose.
All right, the Skills Enhancement Fund money, was all that money used?
Every dime of it, I think. Maybe there's a little bit left.
Mike.
Sorry.
Uh,
In 2018, see on page, the third page there, in actuals, 23 and a half, so it was either spent or it's encumbered in a contract.
So,
It
that
allows,
sequence 1024?
I'm sorry, yes,
All right, so it's either spent or
in a
promised,
contract.
yeah.
It rolls, so there's a significant balance, and that's why it was able to support the 23.5 last year.
Okay, all right. And what does that mean, transferred funding in?
We get a general fund appropriation to, you'll see it on page 1. We get a general fund appropriation of 12 and a half, or have historically. It's sequence 1004, and then the state transfers that funding into a different fund, and that's what you see in 1024. So the general fund appropriates the 12 and a half, and then it is transferred into a fund that we can spend from. So that's why you see it in two different places there.
Okay, all right, I'm always trying to keep track of how many funds there are and where the training money is coming from, and how many, because it's, historically, it's been in so many different silos, so I'm just trying to keep track. So the training fund, in line 1004, you're telling me that's the same money as 1024?
Correct. The state appropriates from the general fund into 1004, and then transfers into a fund that we have access to spend from, and that's 1024.
But the money isn't the same.
There is a large balance. If we don't spend the full 12.5 million, the balance remains.
Does
for
not
us to-
revert.
It does not
Okay.
revert. So that's why you see a larger number from the spend fund.
All right, okay, so, on your bottom line here, where you had submitted appropriation, from FY '19, you showed 17 million or something from the feds, and you only got 5.8. What's that about?
That's the current estimate for 2019. Yeah, that's the federal funds program that's no longer, she's down here. I think
Yeah.
she's looking down
And
here.
this is the
Yeah.
difference you'll
Yeah.
see
That's what
in,
I'm asking.
1021, the Treasury Fund. Those are anticipated federal grants, but, so we had anticipated receiving one in FY '19 that we did not anticipate seeing, receiving going forward. You see the increase there on 1021,
Yes?
right?
Yeah, you're not talking into the microphone,
I'm
so I'm
sorry.
not hearing you well.
It's a grant that we had anticipated in FY '19 that we
Yes.
did not anticipate getting going forward. So that's
You
the,
do not anticipate getting, what was that?
I don't recall, but we can get you that information.
Okay, so it was money that you didn't get. So I guess what I'm asking is this. The governor announced some tollway increases for trucks on the, Northwest Indiana Tollway.
Right.
And some of the money he has proposed to go to expanding international flights, right?
Right.
Is any of that money in this budget?
No, none of that money. We understand that we'll have MOUs with NDOT to be able to have access to those dollars when the opportunities come up, but there's none of that money would be in this budget at this point. Is that true?
Okay. All right, thank you.
Certainly.
Thank you, Mr. Chairman. A quick question or two, very brief. The money that we put in for the Indianapolis to Paris flight, what's our return on investment in regards to that? Is there a cost analysis, benefit analysis? Has that been comprised yet for, what jobs created, et cetera, et cetera? You know where I'm going. What are the outcomes?
Right.
Because we know we deal with statistics, and we want to make, from my perspective, I don't want that to be lost in the Paris to Indianapolis to Paris subsidy.
Well, as you know, we provide kind of a safety net. In this way, it was almost in the form of an incentive. So we were providing $3.5 million the first year, I think $2.2 million the second year. So $5.5 million in total incentive was available to them. And we were paying them for the number of people they had flying on the flight there. So it was a little bit different than a break-even incentive, but it really was kind of that upfront. And it has been going very well. That flight has been, I think, on average 74% filled, and they're pleased with what's coming back as well as what's going over to Paris. So to answer your question, some of the analysis that we had done originally, and again, it's early, that flight just started May 24th or 25th of this year, is about $50 million a year economic impact.
$50 million a year impact?
Right.
And okay.
And we'll spend maybe $5.5 million in incentives over 2 years.
Okay, and so that's in regards to business or people that just can fly to Paris because they can?
We love people to fly to Paris because they can, but we base everything on the economic impact for businesses. In fact, anytime we do any incentives for a potential flight, we're looking at what's the business case. Now, we hope other people do it for pleasure as well, but it's the business case that we're always basing on.
Okay. Mr. Chairman, one more quick question. In regards to, I see you had $310,000 for the Regional City Initiative in your biennial. As you well know, South Bend, Evansville, and Fort Wayne received $40 million for that. And there are other communities like Marion County, Lake County, and Southeast that would like to have regional plans also. Right. Could you enlighten me why we're not doing more than just 310?
Right.
We were in Evansville, and they talked about that $41 million or whatever, it would generate close to $1 billion. So if it's that return, why are we being so lowball on this?
We'd love to do more because Regional Cities has really been a success story. And the 3 out of the 7 that made application in the competitive bid in 2015, each received, they didn't receive it, each had access to $42 million from the state. And that was from a one-time tax amnesty program. So it was money that came up one time. And so you're right, once all of the $126 million is allocated, and they come to us with every plan. So again, we just didn't hand them a check and they get to spend it however we want. They come to us, they have to have a financing stack in place, and we've been putting in, from the state's perspective, about 10% of the total amount of a project. Locally, they put in maybe 15 to 20, and what's really interesting is private developers have brought in about 75% of the cost versus a planned 60%. We were going to be happy with 60%. But what it tells us is doing these regional plans takes out a lot of the risk for a developer, and they're willing to put more money in to get the project done because everybody says this is something we want and we're all going to be using it. So it's been a great program. So we don't have another opportunity for one-time money like that. So what we have been doing doing, as we've gotten other regions to organize, either through an official RDA or otherwise, is providing them some planning grant money to help them get going and up on their feet. So that's been something that we would love to have more money for, but we know that it's just not available right now in that kind of quantity of dollars. So we're actually taking another approach. Something that the governor, as part of his agenda, is the 21st Century Talent Regions. And what we're finding is there's a lot of communities, a lot of regions just don't even know where to start. So this is a tool for help them to start with the basic planning and analysis of what do they have today, education-wise, business-wise, what do they need, quality of place, what do they need in businesses there, with the objective to help them get started, even facilitating, giving some funding to help them facilitate in that planning as well, with the overall objective are three: increase your population, increase your household income, and to increase your education attainment for your region. So we see that as really trying to support, again, that whole regional planning aspect, which we know is so beneficial.
Just a quick follow-up. So, and excuse me, I don't remember. I'm having a legislative moment here. How long do they have to utilize those dollars, each region, to draw down on those dollars?
The 42 million. Actually, they have, what, a total of, did we place a time on it?
What's the timeline?
April of 2020? Yeah.
And so those dollars, if they don't use those dollars by April 2020, what happens to those dollars?
Well, I will tell you, we've already spent almost 120. So, they've got until April for that 6 million. So I don't know what happens to them.
Okay.
Do we stay with the program, or do we? We revert back.
It revert back?
Right.
But you spent 120 of it thus far?
The three regions,
Right.
we have allocated out and given out 120 million so far of the 126 total.
Okay, thank you very much.
And we know we have lots of projects in the pipeline that are great projects.
I thank you for the update. Thank you, Mr. Chairman.
Thank you, I appreciate it.
Good morning. Thank you so much, Mr. Chairman and members of the committee, for allowing FSSA to present our budget presentation for the next biennium. I'd like to start with an overview of our presentation for today. We'll be talking about the divisions and the mission of the Family and Social Services Administration, an introduction to a few of our new team members, our agency priorities, a review of our 2018 successes, our 2019 legislative priorities, and then our fiscal year 2021 budget request. We like to take an approach each day to FSSA to think about what we can do better tomorrow than we have done today. We frame this in a Lewis Carroll approach of, I believe, as many as 6 impossible things before breakfast. And I think as we go through our 2018 successes, you'll find that we've been able to accomplish the impossible here in the last year. We also are taking a whole person approach to our policies. Instead of thinking about and evaluating each program individually, we like to think about how they intersect with the individual. So, for example, instead of just thinking about our SNAP program, our Supplemental Nutrition Assistance Program, we think about the person who might need SNAP, what else do they need? And how can we fill those needs as well to move them in the direction that we really are thinking about? And to this end, we launched the Healthy Opportunities Office January 1st of this year to think about not just the programs that FSSA administers, but how we can intersect beyond FSSA for external stakeholders, external resources to really blend those groups to think about what individuals need. Since August 4th, we've added 10 social context, you might know them as social determinants of health questions, to our SNAP, TANF, and Medicaid applications. 80% of those applications are done online. We get about 120,000 of those applications a month. Since August, we've had over 60,000 responses to these health leads questions about what additional things people need. It's been absolutely extraordinary. Our members want to tell us what they need, and we need to know. So for the first time across the state of Indiana, we actually have a statewide set of data about what our unmet needs are for our population. And I'll tell you, I really enjoy being wrong. I assumed before we asked these questions that our #1 unmet need would be transportation across the state, but it's not. Our #1 unmet need is food. So more than double the number of individuals who apply for SNAP benefits actually have food insecurity. And so we are able to start thinking about, with this statewide data map, what it looks like for as we build and blend programs. Just an overview of our divisions. We have the Division of Aging. This supports development of alternatives to nursing home care and coordinates services through a network of area agencies on aging. We call these our AAAs. The Division of Aging also oversees adult protective services. The money follows the person funding, home and community-based services and waivers. We have a long-term care ombudsman who helps advocate for members. We have the InConnect Alliance, which is a network of programs and services that help people find and meet their needs across the state. And then we also coordinate the Golden Hoosier Awards. The Division of Disability and Rehabilitative Services manages delivery of services to kids and adults with intellectual and developmental disabilities. This is a large program that has multiple bureaus. The ones that you probably know about the most are BEADS, or the Bureau of Developmental Disabilities, the Bureau of Quality Improvement, the First Steps Program, VOC Rehab Services, Blind and Visual Impaired Services, and then Deaf and Hard of Hearing Services. We also have the Office of Early Childhood and Out-of-School Learning. This supervises early care and coordination of out-of-school time programs. We do this under a Paths to Quality initiative that certifies childcare providers based on their level of commitment to education, not just childcare, and have grown that substantially over 2018 to include very high-quality childcare across the state. We also oversee the childcarefinder.in.gov, which is one of our most popular services. We oversee the early Head Start and Head Start coordination with the federal government program, and how to become a child care provider, and our popular program that's expanded to 20 counties, On My Way Pre-K. The Division of Family Resources, we have 110 offices in all Indiana counties, and these receive and approve eligibility for Medicaid, SNAP, and TANF. Under this program, we also do refugee assistance and repatriation programs. The Office of Medicaid Policy and Planning administers healthcare coverage. About 80% of these are in the managed care format. That's Hoosier HealthWise, Hoosier Care Connect, and the Healthy Indiana Plan. Additionally, we have CHIP, which is for children, and then Hoosier RX lives in this program as well. The Division of Mental Health and Addiction works with a network of mental health care providers, and they operate 6 psychiatric hospitals with our new Neurodiagnostic Institute opening in the spring. And we do addiction services, mental health services, the Recovery Works program that helps transition individuals pre-incarceration and post-incarceration into treatment. And then we also do the primary care and behavioral health integration program that co-locates behavioral health services and physical health services in the same place. We're piloting that in 12 locations across the state currently. We also coordinate a large number of opiate grants. Over the last 2 years, we've received over $50 million in funding for this program, and we'll administer those programs continually over the next several years. The Disability Determination Bureau is our 7th and final division. This makes medical determinations of eligibility for Social Security disability and Social Security income. This is an entirely federal program, but intersects with us for administration and oversight. A few new team members. We've expanded and changed the composition of our teams to make sure that we have the right expertise in the right place to administer and oversee these programs. I'm very proud again of our new Healthy Opportunities team that coordinates and has an overview of whole person health rather than just individual access to singular programs. We also have a new, for the first time at the state, Chief Medical Officer for Family and Social Services Administration to make sure that we are aligned with best practices in clinical care. Our data team has grown to include the first data scientist for FSSA. They make things like mapping for social context needs possible. We also have a manager for our data warehouse, which was just awarded the #1 data warehouse in the country for health and human services. So we're very, very proud of where we're moving in data coordination. That allows us to not just do things because they're new, but to do things because they're the right thing to do at the right time in the right place. We have a new members of our legislative team pictured here, so when you see these folks wandering the halls, you'll know who they are. From the left, we have Hamilton Smith. In the middle, Jeremy Hoffman, and then you all know Gus Habig, who I think as of today is the longest standing legislative director in the executive branch. Congrats to Gus for sticking it out with us. Still standing. He is still, though, the only millennial on our executive team, so be nice to him. We also welcome a new Division of Aging leadership. In the middle is Sarah Renner. Sarah is our new Director of the Division of Aging. She is an MBA, MPH with incredible background in policy work and financing for health program services. Prior to going into the public sector, she was the WIC director at ISDH, and so she's got great state background as well and has really helped us make some incredible progress within aging. To her left is Jesse Wyatt, her deputy director, a health law expert. And then to her right is our new medical director for aging, Steve Council, who has several decades of experience in research on how to best deploy aging programs. We have new team members on our Medicaid team as well. On the left, we have Renee Gallagher, who's our new Director of Program Integrity. This program needed some additional attention and expertise, and Renee is the right person for the job. In the middle is James Shin, who is our new Pharmacy Director, and he is really overhauling the way that we look at pharmacy benefits for our Medicaid members. And then to the right is our unicorn of FSSA, Kathy Leonard, who is an actuary. We have not had an internal actuary for the Medicaid team in the past, and she has really enhanced our ability to analyze our partner data around actuary services for setting things like Medicaid rates, et cetera, for the future. We are really happy to have Kathy. She's been with us since the spring. We also welcome, in her second week on the job, a new associate director. We've not had one before within the Division of Disability and Rehabilitative Services to enhance our expertise around providing these programs to our populations with disabilities. I'd like to share with you just our essentially New Year's resolutions from 2018 kind of in buckets. I'm not going to go through these in depth, but just so that you know where we're going and the philosophy behind how we do our work at FSSA, I'll run through these relatively quickly. The first is the idea of embracing the economy of trust as we build our programs. This is a term that I learned on a visit to Goshen, Indiana. There is a community health center in Goshen that has an incredibly vulnerable population that they deal with. But every time I would look at our community health center data and outputs, this was an outlier in their quality, always #1 in quality health outcomes, but always the lowest expense. And so we went to visit and to try to figure out what was the magic behind what they did. And their director, who's been there for about 30 years, decided that instead of going after people, that he would make the basic decision that most people, if given the opportunity to do the right thing, would do that. And so he was going to put all of his resources into those types of programs. And he has been able to really engage people in their health care in a way that is a really standout program. So we decided we would take a leap of faith and model some of our programs after this premise over the last year. And here are a few examples. Our Gateway to Work program, which I'm going to talk a little bit more about in depth in the next few slides, we built a self-attestation program for Gateway to Work. Our assumption is that folks that are engaged or involved in the Gateway to Work program, if we gave them the opportunity to go back to school, to volunteer, to go to work, that they would do that. And all we're asking them to do is tell us that they did. We're not asking them to upload documents. We're not trying to make the program hard. We want really to make the program do what it's supposed to do, which is get people into the next phase of their life in the best way we possibly can. We've also been really creative in the way that we've done pre-K expansion by blending that funding with your, thank you, state dollars for pre-K with our Child Care Development Fund so that we can maximize the number of children that get pre-K services even while we're in pilot growth phase. And then we also are revamping our person-centered planning for the Division of Disability and Rehabilitative Services so that people can be, that want to be at home or in the community can do that in a way that works for them without all the red tape involved. We have decided to become a supporter of public health initiatives, not just a financier for healthcare within FSSA. We're partnering with multiple agencies on multiple really important programs, specifically around infant mortality. I'm going to talk a little bit more about our OB Navigator project with ISDH in a moment. We have, as of July 1st, been the first state in the country to actually have a Medicaid reimbursement rate for community health workers. This expands the healthcare workforce in Indiana, not just within the hallowed halls of healthcare institutions, but in homes and in communities. And we're seeing some really nice uptake for community health workers to be an extension of healthcare growth across the state. We also are implementing the opiate substance use disorder waiver in a way that combines our Medicaid funding for treatment, but also our CURES dollars and our new state opiate response grant, which is $18.2 million a year for the next 2 years, to have a comprehensive, collaborative continuum approach for opiates. We also are piloting in 2 counties a naloxone billing loop. This will make us the first state in the country that doesn't rely on grants for naloxone. Naloxone is a medicine. It should be part of healthcare delivery. And so we have a 2-pronged billing loop process so that providers can bill Indiana Medicaid for naloxone rather than relying on grant dollars that should be used for program builds, not for medicine. This has been a 1.5 years in the making. You would be amazed to see how hard it is to actually change programs like this, but our teams have been incredibly dedicated in getting this done. What this does is it allows us to use those grant dollars for things to start up new programs that then become sustainable. The next is to make the social service process easier so that being a recipient is not a full-time job. We want individuals to get the care that they need and the help that they need in a timely manner so that they can move on to not needing it anymore. One of these, and the big one that we'll talk about in a moment, is our IEDS build. As you know, the IEDS project has been almost 6 years in the making. It goes to pilot in the spring, and that will allow our eligibility. Yes, ma'am, sorry. I'm going to tell you right now. So the IEDS project is an overhaul. It's the largest IT infrastructure overhaul in the history of FSSA. And what it does is it changes the interface that we use to determine eligibility between the local office and the member. It also allows us to communicate data and with members in a more modern way. So instead of only relying on things like mailings for communication, we can email, we can text message, we can really come into the 21st century for the way that we deliver services and eligibility. We have a huge communication initiative to communicate with our members in person-friendly, health-literate language. Some of our communications are, frankly, pretty scary to receive. For our members, they don't necessarily understand what they need to do or what we want from them. So we're working on demystifying the process of how to interact with FSSA. We've even done some small fun projects like our envelope project that changes the look of our envelope so that individuals know what they're getting. It's got our logo on the outside. It has different communications to say action needed quickly, things like that, and folks have been really positive about this experience. We're doing an RFP around the electronic benefits card so that we combine different benefits onto a singular card, combining SNAP and TANF and WIC and different programs into one so that they can be partitioned off, but you only have to manage a singular card. We've co-located services with a pilot in Bloomington that's going well with other divisions and agencies. And we also have a combined pilot with the Department of Corrections and Medicaid so that individuals who are coming out of incarceration immediately are connected with their healthcare coverage so they won't experience a gap. We also have a partnership internally in our agency between cash assistance, nutrition assistance, and our Child Care Development Fund so that the work components that are in each of those programs put those individuals at the top of the list for CCDF so they're not faced with a child care need as they go to work. The next is we are thinking about population health, so larger health for larger groups of individual across healthcare, public health, and social service networks. As you know, last fall we were the first state to go live with open source Medicaid data. What's happened since that time is that our institutes for higher education have now offer classes in how to analyze Medicaid data for crowdsourcing solutions. We had one individual who used this data to build a Health Connector app win the federal CMS prize last week for health app connectivity based on this data use. We have 29 data sets that are open on our data hub that are de-identified for researchers, for communities to use information to help make better decisions for their communities. I'll move through these next few quickly for the sake of time, but really weaving the social determinants of health into the fabric of healthcare delivery, things like transportation, housing, food insecurity, energy assistance, safety, et cetera, has been a huge change for us in 2018. We launched the Open Beds 211 program in March of this year to do real-time connectivity of individuals with substance use disorder to treatment. We've successfully connected people, over 500 individuals, in real time in less than 2 hours at the time that they said, I'm ready for treatment, and having them admitted for inpatient or residential services. We're actually ahead of the game on our timeline for this, and we'll go live with connections to outpatient treatment, and then also going larger into all of mental health treatment connectivity as well. We're very excited about this software as a service program and its applications. Yes? Sorry. Yeah. And then we also, as I mentioned before, added those 10 questions into our SNAP and TANF applications. We're doing person-centered case management to think about unmet social needs, and we have revamped our fee-for-service, our traditional Medicaid, our non-emergency medical transportation program in order to meet those individuals' needs better and in a more streamlined way than we have in the past. I'm going to talk about NEMT in a little bit more depth in a moment. And then, again, we are a data-driven agency, but we haven't necessarily always had our fingertips on the data that we own in the past. And so data matters at the big macro level for making policy decisions, but even more at the micro level when we're interfacing with individuals. We now have a drug dashboard, which interfaces information at our fingertips from across agencies. We have our NGA data project that's allowing us to have a governance strategy around how we look at data internally and how we share it externally. We used our management performance hub to locate where our next opiate treatment programs will be located. We also are sharing Medicaid data with our community mental health centers so that they have access to patient outcomes and can improve their services. And again, new expertise with our data scientist, our actuary, and our chief medical officer within the agency. Now we're going to move into some specific things around agency priorities. The first is the Neurodiagnostic Institute, which will open in the spring of this year. We'll be taking patients for the first time in the late spring. As you know, this coincides with the closing of LaRue Hospital, but the Neurodiagnostic Institute is not a replacement for LaRue Carter. It is a new way to look at individuals with serious mental illness and do a high intensity, rapid diagnostic and treatment evaluation, and then with the goal of reintegrating these individuals faster into the community so that we can keep those wait lists down for our psychiatric network of hospitals across the state. Next is our new benefits portal, which will allow individuals to intersect with us to manage their benefits online in a more user-friendly way than they have in the past, and that will be going live in the spring. We also, for great government service, will be launching in July a singular credentialing program that will be a one-stop shop for provider enrollment, credentialing, and profile updates. The old days of submitting your credentialing request to FSSA, it going off to another entity, then coming back to us, and then going to 4 different managed care partners are done. So this will be a one-stop shop that will greatly decrease the time from application to being a fully credentialed provider. We also will be looking to apply for an 1115 waiver that is similar to the current substance use disorder that just went live in March of this year. This will allow us to enhance our network capacity for serious mental illness services across the state of Indiana. Look for more details to come around this application in the coming months. As I said before, this is a map of our rollout schedule for the eligibility service. The pilot is scheduled for go live in April of 2019 with Wave 1 and Wave 2 to follow. This is, again, a huge technology change for us in order to really do the programs that we do now in a way that meets modern expectations. Let me tell you a little bit about our Gateway to Work program. This launches in January of 2019. About 20% of our HIP members will be required to engage and report their hours in the Gateway to Work qualifying activities. We've done 4 road shows around Gateway to Work over the last 2 years. The required hours over 2019 are 0 for the first 6 months, and we'll phase those in over the first year and a half so that we can teach folks how to do the program. We can start to help educate them on where they might be able to go back to school, to go to work, to enroll in a credentialing or certificate program. Pretty excited about the way that this program has been built over the entirety of 2018. So we really won't look at Gateway to Work members until January 1 of 2020 at redetermination. And in July 1 of 2020, the required hours will be 80 hours per month for 8 of 12 months. This accounts for seasonal variation in individuals who might be working at different times of the year. We have built a network of member-friendly resources. We have a website and a database. We have a member assessment tool that happens at the time of application. We have assistance from all 4 of our health plan partners, including education, communications, and assistance. We have our hours reporting that happens online via the benefit portal. I'll show you a screenshot of that in a moment. You can also report hours by phone, and you can also have your authorized representative report hours for you. So every possible way to report those hours, again, with no additional documentation to make this as easy as possible for members. They also will get a monthly power account statement that will include their Gateway to Work status so that people can keep track of where they are for the year. This is what our website looks like, and will be live in January at the start of this program. There's a mobile version and a desktop version that is very simple and easy to use for members. Quick click, and you can log. Again, we are not looking at these logged hours every month. We are just looking at them at the end of the year, at the time of redetermination, and we'll let people know well in advance if there are things that they need to do to get caught up to get these things taken care of. We're partnering all across the state with not-for-profits, religious organizations, government agencies, and businesses, so our partners can offer programs and resources so that individuals have everything that they need to be successful in this program. Moving on to non-emergency medical transportation. As you know, Indiana Medicaid covers about 1.5 million Hoosiers. In our managed care programs, which is about 80% of the population, the managed care programs, other than a small part of HIP, offer transportation services to medical care as a benefit program. Within our fee-for-service population, so about 250,000 individuals, we offered this benefit, but we didn't coordinate it very well. It was sort of a free-for-all. If you needed transportation, you would have to, as a member, call around and try to find somebody. And a lot of folks gave up, frankly, over time. They could never get somebody to come pick them up, and so they either gave up trying to find transportation, or they actually just gave up going to the doctor. And we wanted to have a much better oversight and understanding of how we could connect these individuals to their transportation benefits so they could actually get their health care needs met. So in June of this year, we, after about a year and a half of planning, launched a central hub service for non-emergency medical transportation for our fee-for-service members. And again, these are really the sickest of our sick patients. These are folks that are on dialysis. These are folks who are on chemotherapy. They're on waiver programs. They're in long-term care facilities, et cetera. So this allows us to have a statewide view of what our transportation network actually looks like, rather than just getting a bill and paying the bill and being done. It also allows our members to use a singular number and a singular online portal to schedule their transportation. Through this process, we were able to really look at transportation not just for non-emergencies, but also emergencies as well, and updated some of our emergency transportation policies to better reflect the needs of the system. So our EMS community was very grateful for clarification around how reimbursement processes could happen within EMS. So for our fiscal year 2018, we again have 240,000 individuals in traditional Medicaid, and our ridership is now between was about 30,000 to 35,000 rides a month, so for this population. Unfortunately, you can see a big gap here that we only served about 3,000 unique individuals. So again, if you think about the number of folks that needed this benefit and the number that we actually served, it was pretty substantial. So since the go live on June 1st, we now average about 42,500 rides a month, 5,000 unique individuals each month and growing, and we've now served over 14,000 unique members since June 1st of 2018. We require providers to drive the most direct route so that we can maximize the number of services that we provide for the network. We now have 246 active providers with over 20 in the credentialing process, and an additional 4 to 5 new providers signing on each week with about 1,200 vehicles that are on the road actively driving. Because we now do this through a single portal, our claims payment rate is over 99%, and we're paying providers within the week of submission of the claim, which is a complete game changer for providers who now have a reliable source of income, especially for our smaller providers who are running, less than 10 facilities or ambulances at a time. And it's really working well, especially for those who have uploaded their information on iPads. They drop the patient off, they submit the claim via iPad, and they get paid in less than 5 days. We've also expanded a novel program while the transportation services are growing to include gas reimbursement so that neighbors, family members, friends who want to drive individuals to their appointments can now get reimbursed for their gas. And we have about 100 individuals that are in the process of getting this done. Obviously, they don't have to become full Medicaid providers, but we have a streamlined application process for this service. We also have now over 100 Hoosiers who are at the call center for NEMT, plus a dedicated nursing facility line for those individuals as well. Another priority for us is looking at our First Steps program. We've had sometimes upwards of 15% growth within First Steps referrals, largely due to the opiate epidemic and infants who are born to moms who have been exposed to substances during pregnancy. What we need to do because of that is strengthen the professional development of our personnel who are going into homes around dealing with families with substance use disorder. And we're using our CURES dollars to do that training, and that is going very well. We've also simplified our policy manual to make it easier for providers. And we're collaborating again across agencies to make sure that First Steps is really enhanced and growing for the continuum. We're with ISDH and DCS in the Help Me Grow program, and we're collaborating with early childhood partners to improve this process. Additionally, we are now going to be using Medicaid reimbursement for a fair number of services within First Steps to enhance what we think will be about freeing up about $8 to $10 million worth of funding so that we can use that to enhance the First Steps program over time. We also are looking closely at our vocational rehabilitation program. As you know, that we went into a program called Order of Selection, August 1st of 2017, which allows us to use our resources for those with the most need within vocational rehabilitation. Since implementation of that process, about 70% of individuals that apply are eligible for prioritized services and are receiving those services in a more timely manner rather than having a wait list. 29% of individuals were deferred but actively referred, not just given a handout, but actively referred to other resources that they can use within their educational space or employment space. So a quick run through some highlights. I'm really proud of the 4,000 person strong team at FSSA who comes to work every day to get this job done. A few successes. Going live for as the first state to reimburse for community health workers. Our Department of Corrections Medicaid enrollment pilot, which is using 9 correctional facilities to integrate individuals into their healthcare services prior to release. The renewal of our Healthy Indiana plan successfully for February of this year. Our substance use disorder waiver that was approved and went live in combination with HIP renewal. The successful expansion of the On My Way pre-K program to 20 counties. Our methadone policy celebrated its first birthday on September 1st with over $2.1 million in methadone programming available to 3,500 Medicaid members for the first time. We also co-hosted the first statewide judicial medication-assisted treatment conference with Chief Justice Rush, with every county of the state represented to learn how the judicial branch of government can be part of the solution for the opiate epidemic. We achieved a SNAP timeliness rate of 99%, putting us in the top quartile for the country. We successfully implemented the 21st Century Cures grant program years 1 and 2 and are looking forward to year 3. The Open Beds 211 program launched in March. We expanded our opiate treatment programs by 5, with 9 more to come in the coming 2 years. We initiated online payment for our First Steps program. And our Logans, as we open a new psychiatric hospital in the spring, our oldest one turned 130 this year and is providing extraordinary services for this vulnerable population. Additionally, we have a home and community-based services waiver amendment to improve direct service professional wages. We implemented the life course framework innovation for case management within our IDDD population. We launched an APS 211 partnership for a 24-hour call center. We launched our social determinants of health assessment tool. For the first time within FSSA, we launched a leadership development program called the Natural Born Pilots and are now graduating our second cohort of these future leaders in state program. And the open source Medicaid data hub, which went live in the spring. For 2019 legislative priorities, you heard the governor's rollout, and we are part of several of those initiatives. As a reminder, Governor Holcomb's pillars are improving the economy, improving the workforce, infrastructure, opiate epidemic and public health improvement, great government service, and civility. One of these programs is our OB Navigator project with ISDH, and this will connect individual moms in high-risk zip codes for infant mortality within Medicaid to services that navigate them through their entire pregnancy and through the infant's first year of life to improve our relatively abysmal infant and maternal mortality rates. This is a evidence-based proven program that will partner with 4 individual arms that exist across the state. The first is the Nurse-Family Partnership, the second is Community Health Workers, the third is Paramedicine, and the final is DCS's Healthy Families program. Next is our HIP Bridge program, which will help us eliminate the cliff effect that occurs when individuals begin to have an income that is over the eligibility criteria for the Healthy Indiana plan. This will be things like having a portable power account so that as individuals go into the marketplace or into employer-sponsored insurance, that they'll have the ability to bridge that gap as they're over income for HIP. They can still pay for services within their new programs. Another part of that proposed package to the federal government will be covering the 60 to 90-day gap that currently exists in employer-sponsored insurance that is a negative disincentive for individuals to move into higher-paying employment. We're very excited about working with the federal government over this coming year to develop this program. The goal is to go live with the HIP Bridge in January of 2020 to correspond with the first time we have a look back with the Gateway to Work program. And then finally, what you came here for today is our budget request for the year, and I'll walk through that relatively quickly. Just as a FYI, a reminder, we'll be talking about the Medicaid forecast in a separate meeting next Monday. I'll look forward to seeing you back then. The current breakdown that we have at our FSSA funding is $10.8 billion in federal, $3.1 billion in state, and $1.4 billion in dedicated funds. We do not have additional requests for our funding for this year. This biennium for us is, the general theme is completion of existing programs that have been in the works for a long time. The IADS project will come to completion. The Neurodiagnostic Institute will open. We have multiple programs around Healthy Indiana Plan that will be completed. And so our goal is to build for the next biennium for the governor's goals that he has given us of statewide expansion of pre-K in 2021. We'll be building our next Healthy Indiana Plan waiver for submission at that time as well. So we have our work cut out for us in this period of time. We also, you'll see in this appropriation request, you'll see what looks like a fairly large decrease in our appropriation. I'm going to show you the next slide next to explain some of that change. And the biggest one is actually in the following slide, but I'll walk through that in a moment. But part of our change package is that the federal government CHIP, which is Children's Health Insurance Program, has a decreased match that we've been watching phase in over time. So we've needed an increase in our state appropriation for that in order to maintain the CHIP program. As you know, because of CHIP, we have a very low rate of uninsurance in Hoosier kids, which is important for us to grow a healthy population. We also have a new appropriation of $1.5 million in 20 and 21 for the school safety program, which is a governor initiative around improving mental health services and connectivity within our Indiana schools. We also have an adjustment to the state psychiatric hospitals because we're building a new one, and that will change at the closing of LaRue Carter and opening of our new NDI facility. We also are asking for an appropriation for a 3.3% salary increase for our state employees that do this work. As you look back in the previous slide with our spreadsheet, we have done some consolidations to make it easier for us to communicate with you around our Medicaid spend. As you know, that's the largest portion of our budget, and so there have been buckets of Medicaid expenditures that have existed outside of the Medicaid forecast in the past. They will now be moved into that Medicaid forecast so that we can talk about them together, so that when you see a line item that says intergovernmental transfer, it'll actually just be part of our Medicaid conversation. And those items are residential services are moving to Medicaid assistance. Medical assistance for wards and hospital care for the indigent are all going to be, you'll see them next week as part of our Medicaid assistance appropriation. We also collapsed our Centers for Independent Living appropriation. Instead of seeing a line item for each of the CILs, you'll see just one singular appropriation for those as well. And so with that, I will thank you for your attention this morning and happy to answer any questions that you might have, not only today, but in the future. My contact information is in your slides and on our website. Thank you very much.
Thank you, Mr. Chairman. Thank you very much. It's a lot of information there. You're talking about charging back for the naloxone. Who is actually going to be reimbursed for that? I didn't understand who the provider would be.
Let me make sure that I have your question correctly. So as we are doing our naloxone billing, when the naloxone is given, there are multiple places where that happens, but first responders, so police, fire, et cetera, currently are relying on grant funding to have their kits supplied and then have to get grants again and again. What we're doing now is we're actually following the patient through this billing loop so that if the first responder delivers the naloxone kit and then the patient is handed off to EMS and then to the hospital, that kit can be resupplied to the entity that delivered it, and then the patient is billed for that naloxone kit through their health care. So Medicaid individuals are the primary pilot for this program so that we can pay for naloxone for entities that use it.
Okay, that's what I thought. So then for the Department of Health's budget, where they are handing out about 37,000 or so kits, so will that, therefore, are they being reimbursed, the State Department of Health, or how are we doing that?
So this is, I call this the convergence of plans over time. So these are in 2 counties right now that are piloting this mechanism for reimbursement. So our hope is that over time, as we're able to grow this program, that the need for the State Department of Health to deliver those kits will decrease and they can use that funding for something else in the future. Since it's not reached maturity yet, we still need to fill that stopgap with our health departments and ISDH in the meantime while we get that up and running.
All right, thank you. And then I see that you have a $3.5 million grant to promote substance abuse, mental health, suicide prevention in 171 schools in 26 counties, right?
Correct.
And then you've also hired a full-time suicide prevention coordinator who's trained 70 local, which is great.
Yes.
So there's that piece, but you're asking, we're going to have 1.5 million in school safety. So what is that piece going to look like?
It's a fantastic question. What we have right now is the essence of variability. So if you look at one school mental health program, you've seen one. With the new appropriation that we have, what we're going to do is we're going to streamline the entire continuum and make this a statewide process so that our schools are trained in early recognition of mental health needs, suicide, et cetera. They also have a streamlined referral process to their local community mental health provider. We're helping with what those MOUs look like so they can have a kind of a boilerplate. This is the things that you should ask about as you have services. We'll do training for on-site evidence-based programming for schools as well, so that they can choose from a menu of implemented programs. So we're really excited about taking the coverage that we have right now is about 75% or so across the state with highly variable levels of effectiveness and penetration to 100% where we know we're doing high quality mental health services and connections with schools.
Okay, so when you say, so school safety is not what we're thinking of, the hard safety issues, like locking doors and things. This is the mental health,
This is the
really,
mental
of
health
the children
piece.
in the classrooms. Okay,
Got it.
so when you say 75% coverage, is this of all school students in the Indiana so far? You have 75% coverage?
There is some level of connection between 75% of schools and a mental health provider, some level. What we're trying to do is help all the boats rise so that we've really got a nice standard of what that should look like.
And in the process, you're creating a program that they can all implement? Okay,
That's
But
correct.
then, we just heard testimony previously that the State Department of Health is going to deploy this CDC survey.
Yes.
Which suggested that we don't know what, and each school can be different, so that's supposed to give them a snapshot, but we're already deploying a program, and it sounds like it's going to be a very broad, not one size fits all big size will fit anyone, take out what you want. But at the same time, after the fact, in a sense, we are going to do this survey, which is only an opt-in. I guess
Yes, so the YRBSS program with ISDH is part of this large package. They are the agency that communicates with the CDC about implementing that. And what that will allow us to do is take what we're doing now in our programming and see if it's working. And that's really what it's for. This is the data analysis of, okay, now that we have mental health in schools, and it can vary from school size to school size. Some schools, as you know, are more resourced than others and may actually choose to have someone embedded in the school all the time. Another school may say, we can't employ a mental health provider in our school, but what we want is to make sure that when we call and say, I've got a referral for you, that your answer is, yes, we'll take them today. So there's going to be a variability in what that program looks like.
I appreciate that, but my understanding is, since we're looking at funding the survey ahead of time, is the survey is going to be done. So it's not really going to tell us if it's working, because the school has to opt in, the parents have to opt in. So it doesn't necessarily mean a program is working. It may be in a school that doesn't have a program or is fully implemented in their mental health.
Right. So we don't have baseline data to start with. So we won't know if anything that we do does anything unless we have a baseline set of information to start
I
with.
appreciate that. I'm not sure you're going to get that, is my point. But I have one more question then with respect to the performance management hub, and I do appreciate the push to use Medicaid data. I think it's very significant. But I was just curious, with the performance hub, is there any chargeback? Because I would imagine of all the departments, yours would be, I mean, in terms of just, if someone else, other department needed their services, and I don't know if this is true, your data set will probably be the largest. Yours will be the biggest drain, if you will.
So I'll be pretty blunt on this one. We actually give MPH more than we take. So they rely very much on our data to do what they do. There are very few things that we ask them to do project-wise for us, because we generally have most of the information that we need within our data warehouse and data team.
Thank you, Mr. Chairman. Thank you very much, Dr. Walther, for your presentation. I just have a couple of questions. One question that I have is, I looked at your division of aging. You have like 6 bullets, but one point in there is the choice program. It's not in there. Could you enlighten me why that isn't in there? We reverted several $1 million from the choice program, and there's over 2,000 plus individuals that are on that waiting list. Could you help me out?
Sorry, Representative Porter, it was certainly not our intention to be comprehensive in the slides, and so there are many other things that aren't in the bullet points that we do that are not on there. It's not by order of priority, just a quick overview of what the divisions cover. So not meant to be a slide of the very important choice program that you help us do.
Okay, so we will have more conversations about the choice
Happy
program?
to do so.
Because I'm really concerned in regards to that, in the waiting list that's been there for years. Another point is the family support waiver that you have. There's also a waiting list on that area also, which is need to be addressed. So I'm not trying to dig in the weeds, but these are important issues that affect all 6+ million of us here in this great state of Indiana. So my question is, there's $500 million in the Medicaid reserves. Well, why could we not look at expanding that program or funding that program also in regards to family support waivers?
Well, currently, we work within the appropriations that we have. These are block granted, so when the funding is used, then we go to a wait list. And so that we work within the parameters that we've been given from our appropriation.
Okay, so we've gone down to the seniors, now we look at families. Let's look at the babies, the pre-K. The program that we have is two preschool programs, or pre-K programs that we had, the early learning as well as on-the-way pre-K programs. The governor is now that there will be no more expansion, but I see in your bullets and his pillars, there are 20 concurrent programs, I believe, but we've taken away $4 million. Help me understand, I mean, we need to discuss that, or enlighten me to the $4 million that the governor is not reverting in regards to the early learning match grant program.
The On My Way pre-K request will remain the same. We have not asked for or looked for a decrease in that funding. We also have blended the eligibility criteria for On My Way pre-K with our federal Child Care Development Fund in order to take as many kids into the program as we possibly can, and we have been successful in doing so. We also are doing capacity building grants for states that want to work toward becoming an on-my-way pre-K provider when we do get to expansion. And so I think that's going to be a huge push in the coming 2 years for training and education and capacity building. We also applied for the Preschool Development Grant, or PDG grant. We'll know by the end of the month whether we receive that. That allows us to build not just a 4-year-old program, but a full comprehensive 0 to 5 strategy to blend all of these funds together so that we really are doing early childhood education and prevention for the 0 to 5 spectrum holistically.
Okay, thank you very much. I don't want to monopolize time. I know we're going to get together again, so I still have some, after you do your forecast, probably some more questions in regards to the TANF and other slide presentation. Again, thank you for being here, and look forward to more conversation as we take care of the people in the state of Indiana. Thank you, Mr. Chairman.
Thank you. I'm not going to ask my questions now, but I have been hearing about 2 months' worth of major complaints about the SET, the transportation issue. And so if sometime I could have somebody from your office contact me and talk about that.
Absolutely. So just a quick update for you. The initial launch of the NEMT program in June did not meet our expectations. However, because of the way that the program has launched and grown, we now have a larger transportation network and connectivity for our most vulnerable members through this process. We did carve out temporarily the nursing facilities from this program because they wanted to make sure that they got their members the transportation that they needed. So what we're seeing is actually members that have never been able to access this benefit before now being able to access it. And so as it grows, we're really thrilled about the progress in this particular component. Again, it speaks to our wanting to meet social context needs for our most vulnerable members. We have a couple of documents that we can share with you. I think you may have received some updated data from me just in the last couple of weeks via email that I sent out to everyone, and then also a slide set of our data. We want to make sure that everyone is in the loop, understanding exactly what we're doing and what kind of outcomes we're seeing. But we're happy to speak individually anytime, myself included.
We're going to go ahead and recess until 1:30.